Good morning, everyone, and welcome to CME Palooza Fall, our kickoff session of our fall meeting. I am Scott Kober, one of the CME Palooza co-producers, and I would like to welcome you to our kickoff session, which is entitled and Not So Common Case Conundrums in CME. And this session is sponsored by Global Academy for Medical Education. A few housekeeping notes before we get started. First of all, I would like to thank all of our many sponsors, our gold sponsors, Genentech and Prova Education, our silver sponsors, ASIM, Forefront Collaborative, Global Academy for Medical Education, Integrity CE, and Practicing Clinicians Exchange, and our bronze sponsors, ACHL, Clinical Care Options, CMEology, Global Education Group, Helio.com Education Lab, Highmark CE, Impact Education, Infograph Ed, Primary Care Network, TVI, RMEI, and Thistle Editorial. A few ways that you can ask questions during this and all of our CME Palooza Fall sessions. You can go to the Google Slides link. You can find this on the live page. So for those of you who are watching this live, right above the live window, there's a link. So click on the link to the Scott sessions. You can send us a text to our CME Palooza text line. The number is 267-666-0CME. That's 0263. Or you can tweet your question using the hashtag CME Palooza. I'll be kind of keeping an eye on all of those different venues and taking as many questions as we can during this and all of our sessions. So finally, a brief speaker disclosure slide just to let you know that what everyone is saying today is their own opinion and does not represent their employer's thoughts. And so with that, I am going to turn this over to Jackie Brooks. Jackie is the Senior Vice President of Medical Strategy at RMEI, and she is going to walk us through our first case for our first team, which is our Medical Education Company Group.
Good morning, everyone. First of all, I want to say thank you to Scott and Derek for inviting me to moderate this, and to Linda and Amanda for actually joining me on this panel. I think that there were a myriad of cases that I could have chosen from, and I think this one's particularly interesting. I think we're going to have fun talking about it, and I hope we get a lot of questions. So we work for a MEC that recently received a nice grant for a relatively ambitious project that involves developing slightly delicate and collaborative partnerships with 5 different healthcare institutions. And we've outlined an initiative in the proposal that would have multiple steps in it. So step 1 involves working with the institution to collect and analyze their data on how they measure biomarkers in patients with non-small cell lung cancer and how the measurement of those biomarkers actually impacts treatment selection. Step 2 is to bring an expert faculty member in on this, show them those data from that institution, and have them work with the institution to deliver an evidence-based program which will subsequently result in some actionable items that you will work with the institution to develop, and you'll present those during the Grand Rounds series. And then finally, in order to reinforce that education, you'll be doing a series of reminder kind of educational programs, either updates to data, reminders about some of the actionable items you talked about, and then your final goal is to measure at the back end whether there's been any impact from that education. And so you're going to ask them to provide data to you again at 6 months. Now, you know, this is designed with the idea in mind that we're constantly being asked to go towards higher standards in CME delivery. So it's really the emphasis recently has been on institutional involvement, partnerships with institutions, the importance of gathering outcomes that are impactful and that can measure institutional change. And then we have to do this in the face of limited funding. So, you know, that was the impetus for the case. So what happens subsequently is we reach out to these institutions. There's a lot of interest from them. They're fascinated by the idea that this will really be directed at their institution rather than be a very general presentation, which they're accustomed to seeing. There seems to be a lot of engagement and involvement. And then as we get closer to the day of our case or our grand rounds presentation, we're not getting anything. And we're contacting them multiple times, and it suddenly becomes clear that we're not going to get these data. And there's various reasons. The data are not easily accessible. They don't have electronic medical records that they can access in that way. They don't want to sign off on the data transfer. The head of the medical education group is not as engaged as your CME administrator was. So the question is then, and I'm going to pose this one to Amanda, because Amanda, you do a lot of partnerships with institutions. So how could you have proactively averted this crisis? And what could you have done differently during the grant development and submission process that may have changed the outcome?
Yeah, this one made me smile when I read this case, because we do a lot of partnerships. And one question I had, just for clarification, and as I understood the case, that you reached out to the institutions after the grant was developed, once the grant was awarded. Is that the case?
I mean, I think what I'm trying to get at here is, no, we didn't. We actually reached out beforehand, but I guess that was one of the questions. Like, if you reached out to them beforehand, would it have made a difference?
Yeah, definitely. That was going to be one of my suggestions, of course, is always to include them in the proposal development. And also include more than just the Office of CME. I know you had mentioned you were working with the director of CME. I know for us, it makes for easier processes when we have the faculty or primary investigator included in the discussions, as well as heads of the department. In this case, it seems like it would be a cancer center. So making sure that more than just the Office of CME was involved could have helped alleviate some of the confusion. And I think what helps also is talking through what measures you're going to be looking at in that proposal development phase. Make sure everyone understands what you're looking for and what you're trying to get, and where those measures can come from. So I think having those discussions helps ensure that the baseline is there, the understanding is there from all parties. The fact that you had 5 institutions is really impressive, and that, of course, just makes for a little bit more tediousness, so that everyone understands what they're doing. But I would say just spelling out everything in the proposal development phase helps tremendously. And I think that there's options to move forward if you can't collect the data that you're wanting to collect. And one thought we would suggest of doing a manual data extraction, where we create a new list or a chart, measurements that we're looking to collect, and then have a nurse or a medical assistant pull a few charts and just write down some of these measures, so we're not going through the ins and outs of working with the system and their EMR.
I mean, that sounds really labor intensive, and obviously you have to contemplate resources and funding. Linda, any thoughts from you?
I just want to say that I can't agree more with Amanda. That is exactly how I was going to answer this part of the case. I can't emphasize enough how it should be really a collaborative process out of the gate when you're working with these institutions, because the healthcare system is so fragmented, and because you had 5 different sites, chances are there were nuances and potential barriers to success that were different across multiple sites.
Mm-hmm.
And so I think having them engaged at the planning phase of grant development and really vetting, truly vetting the study design and getting them on board with that might have led to greater buy-in and commitment to the data extraction. And it would also have helped to, to help the entire planning team to understand, what are some of the restrictions within that EHR? Are all 5 sites on the same EHR platform? I'm going to guess probably not.
Right.
But should that have been potentially an inclusion or an exclusion criteria? Think about the study design, much like you would a clinical trial, where you want to set that up in advance and suggest, do you want all community-based clinical practices? Do you want a mixture where, perhaps some of these should be OCMs that are a little bit more advanced so that there can be some potential peer-to-peer learning across the study. But again, getting those folks engaged out of the gate and having input into the study design is definitely helpful. The challenge I see with that for us from the MEC community is we're not necessarily all of us are there on the forefront that have forged these relationships, with these individual healthcare institutions, health systems. And, from a MEC perspective, I find it sometimes challenging to get to the right person. We really have a great, set of relationships with those CME directors, but getting to those quality and risk managers and the clinical folks that have the responsibilities for quality improvement within their clinical practices is sometimes hard to do because they're very busy clinicians. And so really trying to have ongoing proactive dialogues and discussions to find those institutions that truly have an appetite for change and a readiness and a willingness to participate collaboratively with a MAC and have outside education come in is definitely a recommendation I would make for our community.
Thank you, both of you. I'm going to keep this moving because I think that we could talk about that really, all the time. But I wanted to ask, now that you're in the situation, and I'm sorry, Scott, I'm on the previous slide still. What could you do to salvage the situation? I mean, so, I am going to, full disclosure, we did have those discussions up front and we did involve them in the planning process, and there was that excitement, perhaps not from the correct people. So now that we're in the situation, what do we do next? Any thoughts about how we could continue to work with these institutions and get some data?
Is that for me? Go ahead, Linda.
Okay, I'm going to say Linda.
Thank you. Sorry about that, Amanda. One of the challenges of doing virtual, symposia, I guess. But I was just going to echo again Amanda's sentiments when she mentioned about doing manual chart extractions. But I also agree with you, Jackie. That's very labor intensive. And if you hadn't budgeted in advance for a research coordinator or an internal cheerleader, at each one of those institutions, it can be quite expensive. Another suggestion, if you really think about, the topic of this particular project was, looking at biomarkers in non-small cell lung cancer, and if you're looking at this also from a performance improvement or a process improvement angle, one of the other suggestions that I would make in this case would be to make that the process of improvement. So knowing that this data was not actually readily available in the electronic medical record, it begs the question, how are the clinicians getting this very, very important information to inform treatment decision-making for personalized medicine? So how is there a breakdown in communication, care coordination? Why is this information not being currently reflected in the medical record? So my recommendation would have been potentially to go back to a little bit more of a grassroots effort and help each one of those 5 sites advocate, put a process and a plan in place to improve their EHR and add fields into the electronic medical record. Simple fields, was biomarker testing done? Yes, no. What were the results? And, those results, as we know, clinically speaking in oncology, are really what need to be driving, the treatment decisions. And ultimately, the right treatment for the right patient at the right time leads to cost savings across the system.
Thank you. Scott, you're on. That means there's a question. Is there a question?
Yeah, we've got a couple of questions that have come in. So let me start with this one. So how do you get institutions to see the value of participating in something like this, as opposed to seeing this as another thing they have to add to their workload? So essentially, how do you sell, a project and an involvement of a health system for something like this? Amanda,
do you want to take that question?
Sure. We fortunately have often had the health systems be interested. We very rarely get pushback that they don't want to try efforts to do quality improvement activities. But we always do position it where we, as the MEC, will try to take on as much of the burden as possible. That we, will do the heavy lifting, we'll be the coordinator, we'll make sure that they have the resources they need. So they're essentially just there to get the team together, figure out what their process improvements goals are, what they're going to do, and we're going to help hold their hand. So that has always been our approach. Again, the institutions that we've talked to seem to always be receptive to trying to improve on some measures. So it's just making sure that it's positioned where the burden isn't going to be on them.
I mean, I think from our perspective, we also talked to them a little bit about, macro and MIPS requirements for 2018 and, what they're going to be required to report, and, a little bit of understanding around the fact that they do need to collect those data if they're not collecting them, and be able to analyze them in some meaningful way. The interesting thing is that when we talk to experts in the field, and I don't know, Linda, if you've had the same experience, they say, oh, that's not going to happen, because nobody's going to make it by 2018. So, then it's like a shrug and, oh, well,
Right. Yeah, no, we have the same experience, and that's the value proposition that we take when we're approaching, health systems or community-based clinical practices. The what's in it for me is really look at us as another set of hands on deck. Look at us. Many times, one of the barriers or one of the first responses is, we would absolutely love to do something like this, but unfortunately, we just have limited resources, limited time. We're short-staffed. We hear all of the above, and in our case, we say, well, let us help you with that. Let us really put a structure into place and be very rigorous. Let us help you identify a point person to be, our internal cheerleader at your institution, but we also have a team of people, that will be supporting this effort throughout the course of the commitment. And we find that actually really helps. But we also use the angle of the MACRA and MIPS, and quality reimbursement, value-based care is not going away. And how can we help you with your limited resources to achieve those goals as well?
Okay, so there's one other question that I'll ask you before I let you guys move on. So do you ever have a formal contract written up that you have any of these potential partners sign, or at least commit to, so that you can hold their feet to the fire to some degree?
We do.
Linda, go ahead.
Oh, yeah, we actually will put an agreement in place, and it really outlines roles and responsibilities, what we're going to be providing, what our expectations are with regards to level of commitment, time commitments, and our expected participation from the interprofessional team, like how many healthcare providers, what is our end number expectation for patient data extractions or chart audits. We try to clearly spell that out in advance. And again, going back to the first challenge in this particular case, it really serves us well when you're doing a year-long commitment to remind folks that this is what we set out to do, these were our goals, and these were the expectations from all parties involved.
Okay, so should we move on with part 2 of the case? I think we've come up with a lot of ideas about how you could proactively manage the potential for getting data and working with an institution, and then potentially looking at how you could solve the issue once you've actually found out that you're not going to get the data that you need. So with some creativity, we've managed to be able to salvage the proposal, and we've measured outcomes to level 5. And we're thinking, in the future, it would be really good to see whether we could develop some sort of a proposal and outcomes measures that measure level 6. So in thinking about this, I guess the questions, moving on to the questions, I'd like to ask the second question before I ask the first question. Do you think that we can even achieve this type of outcome with this type of education? And what are the ways that this could be achieved? And I'm going to ask Amanda this question.
I think so. I definitely think level 6 can be achieved. And again, it's always going to be via partnerships. From my perspective, through a partnership, level 6 could be addressed. In this example with biomarkers, the easiest outcome would be looking at that patient data of their quality of life, or their perhaps progression-free survival, or some of those patient-reported outcomes even related to this study. So this program that you had outlined, I think, can be taken to level 6. I think there's other ways to level 6, and it would be perhaps even just surveying patients. So if you were continuing on with this program as you outlined, and you were able to go through and get your level 5 data, you could even just poll some patients within the systems and get their own survey feedback on the activity. So there's a couple ways to obtain level 6 outcomes that a MEC is certainly capable of obtaining.
Linda, do you have anything to add there quickly?
Yeah, I agree completely with Amanda. I do think partnerships are important for level 6 outcome. And I do think that MECs have a value proposition there, and we should be thinking about those collaborative approaches to doing level 6 outcomes.
So then another question for you, Linda, is, one of the things that I really struggle with on a daily basis is really how do you link the patient outcomes directly to the education that you've delivered? And, we do this sometimes with, joint patient and healthcare provider education, and trying to link those outcomes in a meaningful way. And, first of all, the question is, can you link them? And the second question is, do you really need to link them? We feel very strongly that you want to develop the education and then see an outcome, but do we really need to link it directly to that education that we've delivered?
Yeah, I do think that we all struggle with that, because for some of us, that's uncharted territory when you get into, patient level outcomes, population health outcomes, at level 7. And ultimately, that's where we want to go with medical education. But I do think that there are ways to creatively link your education to understand the impact that the education had, not only on improving and moving a team of healthcare professionals forward, but there's ways to link it also to the overall patient health. One of the ways that we've done that is to parse out cohorts in your study design, where one cohort acts like a control group and is not exposed to any education at all by your company. You can't control what else they participate in that disease area, but you can control making sure that they're not a part of your education. And then cohort 2 would be the exposed group that has the educational interventions, support, multiple reinforcement activities. And then at the end, when you look at your composite measures for improvement, in this case, we'd be looking at improvements in the number or volume of biomarker testing being done. You can then surmise that your group that was exposed to more of the education should outperform the group that was not exposed. And we've had some success in doing that in the past using the 2-cohort model.
I would love to talk about this a little bit more because, you know, one of the things that obviously we do as well is things like shared decision making. And I mean, I focus there on biomarkers, but, you know, actually, when you're looking at something that's more qualitative than quantitative, how do you actually measure that? Amanda, do you have a comment on that?
Yeah, you know what? One avenue that we've been going down a little bit more is really that quantitative approach with ethnographic studies. So where we would do an ethnographic study on the patients and use that as a needs assessment for clinician education. In particular, you know, healthcare disparities is a very big issue. Specifically, even, you know, we can look at it in oncology and take that into what's the qualitative information we're pulling from this ethnographic study? What are the patients telling us? And then tie that into a CME activity. So it's a unique approach versus looking at just a separate clinician education versus patient education.
So I guess I have one last question, and you know, this is an easy one, I'm hoping. How often and in which ways do you actually use outcomes that you've generated from previous activities to dictate how you generate proposals moving forward? I mean, you know, the obvious one is absolutely outcomes demonstrating ongoing gaps and needs, but is there anything else that you do that's more creative with those outcomes data? Linda, that's for you.
Well, we use all of our outcomes data. I think it demonstrates not only the impact that you've had, but it's very informative for us to understand and identify where persistent gaps in the healthcare team delivery, you know, still remain. And so they can be prioritized, and then we do use that data, excuse me, to funnel into subsequent grant or future grants, you know, based on what we find. I do think that there's always room for improvement with how we use our outcomes data. We have a pretty high level of commitment to sharing that information. I know a lot of folks are very protective, you know, of their data because it's proprietary. But we actually we have a very high level of commitment for publishing our results. And so we've been published 15 times now in 5 years. So there's definitely a commitment there to share that information with the rest of our colleagues in the CME industry.
Thank you.
I would agree completely with everything Linda said. And I think in addition to publication within our industry, you could be positioning it and publishing it outside of our industry, just to show the extent to which CME, you know, can work. And then also just as an internal analysis of the team and our approach. Was it effective? Did we do a good enough job? Are there things that we as an organization could do better?
Thank you, everyone. I think we've got another question.
So just one more thing. I know that we're running a kind of have to move on to our second case. Somebody did ask where people can find these case studies. So in addition to having our moderators reading through them, you can actually find PDFs of this case study and the case study that we're going to be referring to shortly on the CME Palooza homepage. I put it in one of the blog posts that came up that was on there yesterday. So you can kind of go down and have links to both of these cases. So let me thank Jackie and Linda and Amanda for their discussion, and we could probably take a whole hour just for this one case. But we wanted to move on to our second case, and this is with our hospital-based CME team. And this will be moderated by Ronan O'Byrne. And Ronan is the Director of Continuing Medical Education at the University of Alabama at Birmingham. And he is going to be joined by Andy Krim from the University of North Texas Health Science Center and Karen Bussey from Norton Healthcare. I think I got that right, Karen. So Ronan, I'm going to turn it over to you to get this second case started.
Okay, everybody hear me all right? So at this point, we're going to jump from distributed tactical cooperation among disparate healthcare entities to a focus on some of the more mundane issues that can complicate certification processes. It might be time for a coffee break if accreditation makes you sleepy, but we'll force our way through here. So many thanks to Karen Bussey and Andrew Krim for providing input on approaches to this effort and contributing their insights. Make sure you kind of sleep well at night. So here we go. As you casually slalom through morning traffic while scrolling through your email on your phone, one message stops you in your tracks, and luckily the woman behind you is paying attention. The message is from your Grand Rounds coordinator. It reads as follows. So Margaret sent me copies of the certificates that they issue after Grand Rounds each session for the Remoteville unit. I told her that I wasn't aware that they were issuing certificates and that they are actually supposed to be sent from the CME office upon request. I noticed that the wording on the certificates for the MDs is incorrect. She said that they have older physicians that have retired and they want the certificates at the end of the session since they don't use internet or email. The administrative contact for Remoteville is Pat Walker. She's out on medical leave. The attendance hasn't been entered for the September sessions. She asked if they could go ahead and give out certificates since they are having sessions at 11 today. So even after 2.5 years on the job, you still feel a little like an ACCME neophyte. You find that you can follow orders much more easily than you can interpret policy. So when you get to the office, you have a quick huddle with your team. Is it okay for the Remoteville unit to hand out their own certificates? You ask this to mostly blank stares. No one seems sure whether or not this presents a compliance problem. So you keep trying. Do we have any records on how this policy came about? That's still, and nobody seems to know precisely how this happened. So your coordinator spends the next few hours going through past applications in your system and electronic records, but finds nothing concrete. So apparently whoever created this arrangement is long gone. You have back-to-back meetings from 9 to 12, so you ask your coordinator to contact Margaret. Just ask her to hold off on handing out any certificates for the session today and tell her that we'll look into this. You instruct her before heading off to your meeting. So the morning zips by, and when you get back to your office, there's a voicemail from Dr. Waverly, who's Director of Educational Activities at the Remoteville unit. And she's asking you to get back in touch with her as soon as possible. You call her and explain your position. She's very polite, but obviously a little irked that this is taking up a valuable part of her day, probably the 10 minutes she has to wolf down a sandwich between meetings and clinic. She tells you that Remoteville has been issuing paper certificates at the end of Grand Rounds sessions since forever. Okay, so Remoteville is the only sponsor of any activity like this in the 5-county region, she tells you. A lot of the physicians who come in are retired or close to retirement. They really like to come to sessions on campus and attend them in person. They also contribute to offset a substantial portion of the cost that keeps these sessions going. So while she understands that there should be a process behind recording attendance and handing out certificates, she's hopeful that a solution can be worked on that to satisfy all parties. You tell her that you'll research it a little bit further, talk to your team, and get back to her within a week with your recommendation. All right, so questions for discussion. And the first one we will toss to Andrew. Andrew, does this current policy violate ACCME standards? If so, how?
It does not, actually. The ACCME has no policy on certificates. They refer that to the accreditation organization. So in this case, it would be the AMA.
And so what would the AMA have to say?
AMA would say you don't have to give out a certificate unless the physician requests one, which it sounds like you're doing. If you put anything, if you hand out anything that has the number of AMA credit hours listed, then you have to put the correct accreditation statement on the certificate.
Yes, you do have to get that wording right. So, yeah, bottom line, there are no issues to address with ACCME. They pass it off to AMA or the accrediting body. It might be nursing, it could be pharmacy, and they let those folks determine the standard. Karen, if we could go to you and ask you to address question 2. In your mind, what are the primary issues that need to be addressed and which are maybe not as critical?
I'll address this as they're a joint provider and we're the accredited body. We're accredited by Kentucky Medical Association. So I think more the issue is the policies and procedures that are set up for attendance. So for example, are they doing a roster or sign-in sheet? And then how is that information getting back to us? Because as the accredited provider, we are required to maintain physician attendance records for up to 6 years. So to me, that would be more the issue. In respect to a certificate, if they are wanting to give a certificate, we would work with them and make sure that all the correct information is on there, as is noted, and we would probably provide them a template to use for the activity. So to me, that would be more the primary issue, is the policy for maintaining the attendance records of the attendees for the session.
And so just as a matter of opinion on that, would you feel like it might be good, bad, indifferent practice for an accrediting group to allow this sort of remote distribution of certificates?
We probably would not allow that on an ongoing basis without any type of monitoring. So for transcripts, once they are entered into our particular system, we would recommend to Pat that she go online and pull the transcripts from our system. And if she does have physicians that are not comfortable with computer or internet, then what we would do is show her how she could pull the transcripts and distribute those to the attendees. And then that would assure that they are getting the actual correct statement and information for documentation. So that would probably be our process.
Mm-hmm. Well, the interesting part about that is access to transcripts for individuals by a person who is remote. So you have, your system presumably might require an individual login.
No, our system for physicians to pull transcripts is internet, not intranet. So
Gotcha.
They essentially just go to a link, enter their license number and the time period that they want their transcripts, and they get a PDF and they can either print it or email it to themselves.
Mm-hmm.
And they also get a certificate for a specific activity. So if they want it for a certain session that they attended, they can also get a quote unquote a certificate for that includes all the correct information. And that is online. We do have instances where physicians don't have computers or internet, and we'll provide that for them and just mail them the information that they request. So we would probably want Remoteville to tie into and use our system because we would be entering the data, then everything is up to date and current.
Mm-hmm. Yeah, it's an elegant solution that if you do by physician number, then individuals who aren't the physician themselves can actually generate the transcript for them.
Yes, and it's done in real time as attendance is entered. So they always have access to the most current data in respect to credits for Category 1.
Okay, thank you. So we might, Andrew, do you have anything to add to that from the perspective of an academic medical center?
Yeah, so we've struggled with this. We joint provide RSSs to hospitals around the state, some outside the region. And this is an area we've struggled with. Our primary policy is that the physician should be the one logging on, claiming the credit, and printing off their certificate. But we do understand, as soon as we implemented that, we found a lot of barriers and a lot of walls that weren't going to be able to make that happen in all scenarios. We have, in the past, overcome that by passing out a record of participation. that just lists the title of the activity, the date of the activity, and the location of the activity, and a link to where you can go find out more information. It does not list the credits. And a link to where you can go and print off a certificate if you need one there. And then we would actually mail transcripts or certificates to those individuals that specifically requested one if they did not have access to the internet.
So it's a little bit more laborious.
So Ronan, we have a question that came in. So so this person is asking, this is not me, this is them. I also have many retired physicians who attend grand rounds at our hospital. How much should we cater our policies to their needs as opposed to the needs of our actively practicing physicians?
That is a good question. Andrew, do you look like you wanted to maybe address that?
Yeah, we have the issue too. In fact, we have a grand round starting in about 2.5 hours where a large portion of the audience is probably going to be retired physicians. The ACCME does not specify what needs we need to take. They don't say, you only need to focus on physicians who are currently practicing. They talk about the needs of physicians. If they're licensed, we're going to pay attention to what needs they have. We would like to align the needs of our activities, and we do so mostly with what the organizational needs are. If that happens to align with the needs of the retired physician, then so be it. We're probably not going to do a special grand rounds just for a series of special topics just for retired physicians. But if they find the need in the education that we've aligned, the better. So.
Karen, anything to add on that?
Was the question related to the certificate and transcripts or creating special programs?
I suspect probably towards the transcripts and certificates and just kind of making a process easier for the retired physicians. That's my guess. That's sort of how I read the question.
Okay, and answering from that perspective, our approach for Norton Healthcare is we try to be customer focused, and if a physician is retired and has problems, we'd go ahead and see what they needed and try to meet their need. We actually had, last week I answered the phone and someone attended a program, we do online surveys, and they had a problem getting a link. I literally took 5 minutes with them and asked him the surveys, went through the SurveyMonkey questionnaire, and then was able to get his transcript at the end, and I printed it and mailed it to him. So we try to accommodate needs because we do recognize as we're getting more technological, there is that generation gap and people just aren't as tech savvy. So that's kind of our philosophy with our team.
Yeah, we started broadcasting the grand rounds, some of the grand rounds that we produce. And week after week, we have, hey, I can't access my certificates. How do where's the link I go to? And we devote quite amount of staff time, all of us here during the lunchtime period, answering those questions and making sure those needs are met.
Mm-hmm.
Yeah. And so from the perspective of UAB here, just to kind of add to that question, is that, when we have what is essentially 4 to 5 remote campuses where residents would go for specific programs in rural medicine or others. They interact with physicians who are in a relatively rural environment, and these are sort of, I wouldn't say micro community, they're communities within a larger macro community. And so we want to go as far as possible to maintain the community aspect of this. And I think in this situation, what we have is a lot of physicians who might not be practicing much anymore, but are coming to campus, engaging with current physicians. And really there's a level of practice and a level of communication practice from these physicians that doesn't need to be lost by perhaps alienating them in any particular way. So we would accommodate as much as we could. With that said, there are limits to doing that, but these are folks who it's valuable to the institution to keep them engaged. We would go as far as we could with it.
So here's another question that came in, and I'll sort of read into this a little bit. So the question is, how many people do you have in your departments? And my guess is because you're doing a lot of hands-on, one-on-one maintenance with these physicians. So I guess perhaps a follow-up to this initial question is, how would a one-person CME department be able to handle these sorts of issues?
Oh, well, from my perspective, a one-person CME department could not. But let me turn it over to Andrew and ask him what he might have to say about that.
Yeah, we've got 9 people in our office. Not everyone's devoted to doing user assistance like that. Everyone can, though, and we take turns doing it. I think 2 or 3 of us are the ones who actually do it. For a small office, a smaller office than what we have, even a one-person office. Developing an FAQ, putting it online, and on how to solve some of the common problems you see on a regular basis. A lot of the calls we get, technical difficulties, they're all related to the same issues. They can't find the link. They can't, when they hit submit, nothing happened. A lot of times it's an issue on their end, but we've run into it. We've been able to solve it for someone else, and we give them other things to try. Developing an FAQ would certainly help do that. Making that available, sending it out with your email announcements, things along those lines.
Karen, anything to add to that?
We're a staff of 3.5, and what I would do, I concur with what was said, but we would probably try to do some activity director training one-on-one and go through the process with them to make sure they understand, so they could be the point person for their attendees at the remote location, as well as the online information on the computer and stuff.
Yeah, and I think the question, I suppose, I didn't really answer the first part. It was like, how many departments and units you're dealing with? Well, here at UAB, we're dealing with 28 departments, an additional 54 divisions, and probably in the order of about, the faculty bounces up and down. It's hard to tell, but somewhere between 1,700 and 1,800. Wow. So it's very difficult to do that. But I think maybe this leads into an additional question of what alternatives are available for a mishmash of, oh, these folks over here can't access, are unwilling, let's be honest, so they're just unwilling to go online. They've done it this way forever, right? They go to the session, they talk, they might get some lunch, they chat with some folks, and they get their certificate. So number 3, I think we've kind of dealt with that in the first one. I'm not sure we need to put in a call to the ACCME, but what kind of alternatives are available to this sort of ad hoc approach of, okay, you have a lot of folks who want their certificate there and then give it to them? How would we address it policy-wise? Andrew, could you take a stab at that?
Yeah, on our end, like I said earlier, we've developed just a record participation that doesn't list the credit hours, or we provide a template that does list the credit hours and say this is exactly what you need to pass out in those situations. We've tried different methods throughout the year. We had before we went digital, we had a credit claim form where you filled out, but it was perforated at the top was a record of participation, but you had to fill in the bottom. We did carbon copy forms, but just providing those, we let them know the sign-in sheet is the ultimate record of what we have, or the online credit claim is the ultimate record of what we have now. If your name's not in there and the state board calls to verify your credit hours, we can't say you were there, even if you have a certificate.
Mm-hmm. Karen, anything policy-wise that you might do to kind of deal with this issue?
Pretty much the same. What we would do is just work with the activity director for those physicians and provide a certificate template that was updated. And then again, the roster is what would be the ultimate attendance and what was entered into the record, but that would give them the hard copy they feel that they needed, is what we would do.
Mm-hmm. Yeah, and I think it's also possible to run into this situation. And again, within the academic medical centers, you got docs who are heavily involved with their societies, their board, their other, Society for General Internal Medicine, Society of ACO, all these different kind of bodies where physicians have these sort of loyalties to, and they become part of staff for running these organizations. They bring accrediting opportunities to you, but you wind up dealing with some remote entities then. And yeah, you have to sort of set a policy that would either allow it or disallow it, or provide an option, which might be something like a certificate of attendance. You'd have to invest in a technological solution, but there's probably, you can draft a policy with some very specific criteria that doesn't allow the cat out of the bag. In this particular instance, we tried to define a very specific set of criteria that would eliminate the possibility that all of our 28 departments and 54 divisions would say, wait a minute, we got some grand rounds going, let us hand out the certificates here.
Yeah, I think if you discount the needs or discount the value of a retired physician coming to some of your activities, you do so at your own peril. A lot of opportunities, they're still involved in the community, they're still involved in organizations, and a lot of opportunities, I know a lot of our opportunities have come from physicians who are retired but are still involved in one way or the other. They provide access to organizations you wouldn't otherwise have access to help attaining those higher level outcomes or some of those community health organized projects that you're looking at.
Yes, I agree entirely. And they provide other benefits that are not as easy to see to the institution. Connection to people who, a clerkship, out in various communities, as I mentioned, our rural program, all these sort of, it's a relationship that could not be easily replaced if you were to sort of ignore their needs and alienate them in some way. And I certainly agree with that.
Correct.
And I imagine that the circumstance would be similar within an organization like yours, Karen, where you're dealing with several hospitals in different areas. I mean, do physicians have some sort of loyalty to the institution where they worked and like to come back to stay engaged?
Yeah, we have a lot of physicians that are retired and they still maintain their license into a lot of our activities. At Norton Healthcare, we have 5 facilities in Louisville, and we have 8 affiliate hospitals throughout Kentucky and Southern Indiana. And our medical staff that are employed is about 700 physicians, plus all the other physicians that have privileges at all of our sites. So we are pretty big, and we do have a lot of physicians that are engaged in an ongoing basis, even when they retire, that are seeking ongoing educational opportunity.
Okay. So, Scott?
Yeah, no, I think I think we're running up against close to the end of the session. I don't know if you have any closing thoughts you want to give on this case, Ronan, and then before I sort of wrap this up.
Well, I want to thank Karen and Andrew again for their participation and their insights. Appreciate that very much. To anybody who is facing an issue like this, I think the general recommendation would appear to be draft a policy. And the AMA kind of hints at this too when you communicate with them, that maybe it's not a great idea, but if you need to do it, draft a policy. Set some specific criteria. Again, it might be geographic. It might be related to the specifics of the population involved. Get a signed agreement and codify the practice so that people know, and it doesn't slip by and all of a sudden pop up again and you don't know what to do.
I've got one more thing to add to that. Take it a step further, draft a policy, set it up as a PDSA to test it out, and that way it helps you with your accreditation self-study as you go forward as a program improvement. So.
Awesome. I think that's very forward-thinking advice there, Andy. So I think this has been a great session. We had a sort of our first case was sort of a macro issue, and this sort of was a little bit more of a micro issue. So I think these were very interesting. So for folks who are watching this either live or the enduring version, there is a brief survey. We try to gauge the thoughts of our audience for CME Palooza Fall. So there's a survey link at the top of the live tab. So if you could please complete that either now or at the end of the day. That'll get a sense of who is watching and what they're watching for CME Palooza Fall. So for those who are watching this live and are interested in viewing our next session, which is our CME Grant Mythbusters session, you'll just need to refresh your browser here in the next couple minutes as we transition from this session to our next session, and we will begin that session shortly. So with that, I'd like to thank Ronan and Karen and Andy from our hospital team, and Jackie, who had to jump off quick meeting afterwards, along with Linda and Amanda from our initial MEC team. So thanks, everyone, and we hope to see everyone very, very soon.
You're welcome.